Good afternoon, students, teachers, and peers. My name is Althea, and I'm a student nurse. I am going to give you a brief presentation about chronic obstructive pulmonary disease. A 62-year-old male, David Nassar, who was admitted to the emergency department at 2200 hours due to the inspection of COPD. David presents signs and symptoms of dyspnea, hypercapnia, inflammation, hypertension, hypoxemia, tachycardia, and tachypnea. These symptoms suggest Mr. Nassar has an exacerbation of chronic obstructive pulmonary disease and COVID-19. I will be discussing the A to E assessment approach along with my clinical decision-making for high-priority nursing interventions, nursing considerations of therapies and medication in treating David's condition. David's airway is clear and patent, and he is breathing on his own, indicating that there is no serious harm to his airway, for example, an obstruction. I will continuously monitor David's airway to avoid any serious harm or obstruction. I will also recommend David sitting in a high valgus position to allow him to breathe better and keep his airway clear. David has a respiratory rate of 30 breaths per minute, with a low oxygen saturation of 78%, indicating tachypnea and hypoxemia. His diminished breath sounds, wheezing, crackles, and using accessory muscles to suggest that David is in respiratory distress due to a possible COVID-19 infection and poor oxygenation. To manage his hypoxemia, I will apply high-flow oxygen through a nasal cannula. Bronchodilators such as salbutamol and corticosteroids would reduce the inflammation and bronchospasm in David's airway. With David's respiratory acidosis, which is evident in his ABG results, I will reassess ABG every 4 hours to monitor his respiratory status. David shows symptoms of tachycardia and hypertension, which are caused by distress and respiratory distress. Administering beta blockers and adenosine are beneficial in managing his rapid heart rate. To treat hypertension, medications such as diuretics, ACE inhibitors, SNS inhibitors, and calcium channel blockers can bring down the blood pressure to a stable level. David's classical coma of 14 out of 15 is a sign that he is in a confused and distressed state. This is associated with hypoxemia and hypercapnia. It is important to closely monitor his neurological status to make sure that he is well and conscious and to avoid any deterioration of his respiratory status. As indicated in the case study, David is verbal, suggesting an infection of COVID-19. I would monitor David's body temperature regularly and administer medications such as antipyretics and paracetamol. These medications are effective in treating his fever. It is important to implement high-priority nursing interventions to manage David's exacerbation of COPD and to improve his quality of life. These include oxygen therapy, bronchodilators, corticosteroids, and high valgus position. Firstly, delivering oxygen therapy is effective in managing David's low oxygen saturation of 78%. Studies have highlighted that a target of SpO2 between 88% to 92% is highly recommended for David. Oxygen therapy overall improves the oxygen saturation as well as the atrial blood gas, such as SaO2 and PaO2. Additionally, it does help reduce the breathlessness in the presence of hypoxemia that David is experiencing. Nasal cannula is a highly recommended method of delivering oxygen as it is comfortable, ease of use, and no risk of rebreathing carbon dioxide, and can administer nebulized bronchodilator at the same time. David is experiencing hypercapnic respiratory failure and respiratory acidosis, which is evident in his ABG results. A PA2 of 55 mmHg and pH of 7.30. A non-invasive or invasive ventilation should be required due to the inability to effectively remove the carbon dioxide out of David's blood system. Secondly, bronchodilators are an effective intervention in managing David's respiratory status and improve the quality of life. Bronchodilators can help reduce the symptoms of dyspnea, wheezing, and coughing that David is experiencing. Research has shown that the appropriate and effective use for older adults is the metered-dose inhaler, MDI. However, it can be challenging as it requires proper coordination and inhalation technique. The mechanism of action of bronchodilators targets the beta-2 receptor in the lung airways. Once the receptor is activated, it relaxes the smooth muscle of the airway. Therefore, bronchodilators such as salbutamol and iptacopan can help David breathe better. Corticosteroids play a pivotal role in improving gas exchange, systemic inflammation, and beta-2 receptor sensitivity. The inhaled corticosteroids are an anti-inflammatory drugs and are commonly used in the management of COPD symptoms such as schizophrenia, cough, and spectrum production. Research has shown that ICS has clinical benefits, which include the reduction rate of exacerbation of COPD, shorter hospital stays, and reduced risk of treatment failure. Lastly, high Fowler's position is an essential nursing intervention as it promotes oxygenation by maximizing the chest expansion and relieves the abdominal muscular tension. Therefore, studies have recommended that David should sit upright in a position with the head of the bed elevated between 60 to 90 degrees to allow him to breathe better. Now, I want to call your attention on the nursing considerations of therapies and medications to manage David's exacerbation of COPD. These nursing interventions are further explained with support from current literature resources. Applying oxygen therapy is an important therapy to consider as it decreases minute ventilation and hypocapnia. The initial assessment will involve David's low oxygen saturation of 78% and a high breathing rate of 30 breaths per minute. As a result, I would apply oxygen therapy to manage his hypoxemia and tachypnea. Oxygen therapy involves delivering 1 to 2 liters of oxygen through a nasal cannula and carefully titrate oxygen to achieve an SpO2 between 88 to 92%. I will also administer bronchodilators if it's required and continue to observe David's ABG. However, delivering elevated oxygen levels can lead to potential hyperventilation, hypocapnia, carbon dioxide necrosis, and oxygen toxicity. This would develop symptoms such as non-productive cough, substernal pain, and pulmonary hemorrhage. Salbutamol is a type of bronchodilator used to treat airway inflammation and bronchospasm. I would monitor David's respiratory rate, breath sounds, and SpO2 before and after the use of salbutamol to assess the effectiveness. The administration of salbutamol, highlighted by a recent study, is to use metered-dose inhaler, and it is recommended that David should take 4 to 8 inhalations every 1 to 6 hours. Common side effects include tremor, tachycardia, hypoglycemia, hypokalemia, and hypomagnesemia. Ipratropium is an anticholinergic drug that inhibits the muscarinic receptors of the pulmonary smooth muscle. Given David's dyspnea, wheezing, and bronchospasm in the airflow, administering 0.5 of ipratropium 3 to 4 times a day by nebulizer is ideal to treat David's airflow blockage. Few side effects to when taking ipratropium, such as dry mouth, constipation, urinary retention, tachycardia, and blurred vision. It is important to have the right dosage to avoid these side effects. To treat David's inflammation, prednisolone is considered. It is a type of corticosteroid that works by suppressing the migration of leukocytes and reverses the increased capillary permeability, therefore suppressing the immune system. A standard 40 milligrams of oral prednisolone daily for 5 days is highly recommended for David, and it should be taken with food. However, prednisolone can increase the risk of hypoglycemia, resulting in decreased pancreatic insulin production and induction of insulin resistance. Erythromycin is a microclide antibiotic that has antimicrobial properties that inhibits the inflammatory cytokines and has shown to reduce the mucus production and improve lung function. David is experiencing pneumonia associated with COPD and COVID-19, administering 500 milligrams of erythromycin orally per day for 3 days can treat David's infection of COVID-19. Adverse effects involves dizziness, headache, vertigo, renal failure, palpitations, and chest pains. Lastly, to address COVID-19 symptoms, David will receive nirmatrelvir and ritonavir. The standard regime involves administering 300 milligrams of nirmatrelvir and 100 milligrams of ritonavir. They are orally administered twice daily for 5 days. I will closely monitor for adverse effects such as dysuria, diarrhea, hypertension, and myalgia. To conclude, it is essential to manage Mr. Nassel's exacerbation of COPD and COVID-19 through a comprehensive approach to help him stabilize his condition and improve his quality of life. This is done through a careful monitoring, implementing high-priority nursing interventions and medication administration. As a nurse, it is my responsibility to ensure that Mr. Nassel's evolving clinical needs are being adapted in every aspect of his care. Thank you so much for your attention.